Hello, my name is Dr. Beyer. I'm a psychiatrist board certified by the American Board of Psychiatry and Neurology. I'm here to speak with you today about attention deficit hyperactivity disorder. What is the roadmap for today? Our objectives. To begin, we will discuss some practical guidance and an overview on what to do with a patient who comes into your office endorsing symptoms of attentional difficulties and perhaps even self-diagnosing with ADHD. We will then move on to discuss exactly what it is that we mean by attention. What are the biological substrates of this phenomenon? We will then review the relevant diagnostic criteria, epidemiology, etiology, and comorbidity that is often seen with ADHD. We will then review a diagnostic workup, a differential diagnosis, and methods of evaluating the patient for ADHD. We will then conclude with an overview of treatment options, paying particular attention to the behavioral and psychosocial interventions since they are often neglected in favor of an exclusively pharmacological approach. Bottom line up front, what to do with a patient who comes into your office endorsing symptoms of ADHD. If you're a primary care physician, you start with your history and physical. If you're a mental health doctor, you start with your normal intake. Once you've completed your normal intake, your normal history and physical, then you would move on to a specific evaluation for ADHD. There are any number of appropriate screening tools that you can use to guide your diagnostic interview, or you can just use the DSM-5 criteria as they're laid out in the DSM. They're readily available in multiple sources to include UpToDate, and even Google will have them. You'll find them. Using those questions to guide your interview. You want to elicit specific symptoms from the patient, and then follow those symptoms to see how impairing they are. Just having frequent forgetfulness of everyday activities like paying bills or losing your keys or your phone is not sufficient to meet a diagnosis of ADHD. You must also see how those symptoms cause impairment or dysfunction in some area of functioning in the person's life, either occupationally, socially or interpersonally, or perhaps academically. Once you have obtained the patient's report of symptoms and impairment from said symptoms, you then move forward to obtain collateral information. Since ADHD is a neurodevelopmental disorder, it should be present, according to DSM-5, prior to the age of 12. Therefore, the best collateral informant is often a parent. I am of the practice of calling a patient's mother or their father in session with the patient's permission. If the patient does not provide permission to speak to the parent, you can ask to speak to some other informant, such as a spouse or significant other. Asking that person, that informant, the same sorts of questions you already asked the patient, looking for symptoms, symptom number, and the degree of impairment as a result of those symptoms. It is important to keep in mind during your questioning to look out for other mental health conditions which might cause symptoms of inattentiveness or poor concentration. It doesn't take too much imagination to realize that someone who is intoxicated is going to not be able to attend very well. However, being intoxicated is not the same thing as ADHD. So look out for depression, insomnia, anxiety, and the like. Once you have the patient's report of symptoms, patient's report of impairment, a collateral informant's report of symptoms, a collateral informant's report of impairment, and you have sufficiently ruled out any confounding diagnosis such as a substance use disorder, an anxiety or depressive condition, or perhaps even a progressive cognitive disorder such as schizophrenia or something of that sort, you might make a diagnosis of ADHD. It's important to keep in mind that ADHD is a clinical diagnosis, meaning it's a judgment call. You look for the symptoms, you look for the impairment from the patient's report. You can use some aspects of the mental status exam to corroborate the report and the collateral information, but ultimately the diagnosis is a clinical diagnosis, which means it's a judgment call on behalf of the physician. Once you have made your diagnosis, you then discuss treatment options with the patient, making sure to discuss the behavioral and psychosocial interventions first, since those are often the most long-lasting interventions. Once the patient learns how to do them and sets them up in their life, they are probably going to be very helpful moving forward. Once the patient has learned and implemented the behavioral and psychosocial interventions, you can then consider pharmacological interventions. I am of the practice to begin with the non-stimulant medications. You wouldn't be wrong to begin with a stimulant medication. However, it's important to keep in mind that stimulant medications are controlled substances, they are addictive, and they carry with them risks, as most medications do. I tend to start with Strattera or guanfacine, and then perhaps use Wellbutrin for a time. If any of these work, great. There's going to be less risk involved, less risk of addiction before going to the stimulant medications such as Concerta or Adderall. Whenever one is talking about a mental health disorder, it's always helpful to have some frame of reference, some way of understanding what it is we're talking about. People in the mental health field often will say something along the lines of, the mind is what the brain does, trying to harmonize for ourselves exactly what the mind is doing, what are our depressive and anxiety conditions, and how do they relate to the biological substrate, the brain, that we study in neuroscience. Now, to provide some sort of structure for evaluating the different functions of the brain and how they relate to the disorders that we diagnose, it can be helpful to kind of break things down into 4 main domains, each one building upon the one that comes before it. This framework comes from a psychiatrist named John Ratey and his book, The User's Guide to the Brain, which is almost 20 years old now, but I find is a useful framework for understanding and building upon a neuroscience-based understanding of mental health conditions. So the first layer is perception. Our intellectual life, our emotional life is based in perception. Aquinas was fond of saying that there is nothing in the intellect that is not first in the senses. Therefore, everything that gets to the mind or one's experience of oneself has to begin in the senses. So perception, vision, touch, taste, smell, hearing, all of these things, that is the beginning of our intellectual life. That information, that primary sense data, gets to the brain, and then the various cognitive functions start to process it or work on it. And so things such as attention, awareness, awareness of thought or meta thought, all of those are cognitive functions which are working with the primary sense data. And then you have even higher order functions, so the third layer, where you have specific brain functions, which will integrate the different lower level functions of the brain to get things like movement, memory, emotion, language, and all the different functions of the brain that we see that are a little bit closer to our understanding of ourselves and our emotional and intellectual lives. The final layer of functioning, the highest order, is the most integrative, where you have a sense of self, a sense of free will. Where does that come from? There's no specific point in the brain that you point to. It is rather an emergent phenomenon that comes from the lower level functioning and cognitive units that are in the brain and their relationships and working with one another. So beginning with perception and then rising to a level of cognition with various other lower level, less integrated functions. Integrating those functions to get more complex functions such as movement, memory, emotion, and language, and then finally the highest and most integrative aspect of our brain life, our mind life, where we have a sense of self, our executive functioning, decision making, and things of that sort. So specifically looking at ADHD, that's pretty far down on the line. It's one of the basic cognitive functions like attention, which is a different area to find and hunt for a disorder than to look for depression, let's say, which would occur in a higher order level of integration within the brain. It's not uncommon for us to miss a diagnosis of a perception problem and rather attribute it to a level 4 problem, a problem of the mind, and calling it depression or anxiety, when in fact, oh no, this person is depressed and anxious because they can't relate to other people because they don't see the way other people see, or they don't hear the way other people hear. So it's important to keep in mind that different levels of functioning, and right now, since we're talking about ADHD, we're at a relatively lower level of integration of the brain that we're talking about. So what exactly is attention anyways? Well, it's the brain's ability to weigh the relative importance of various stimuli and select which one receives the brain's focus. Which one stimulus is the one that is being evaluated by the brain. And all those different cognitive units working with one another on what primary sense data, what perceptual information gets processed first. Your ability to attend means you are picking which primary sense data is getting processed. The brain has a limited capacity to attend to something. You cannot attend to everything at once. That is most likely because those same cognitive units which are processing all that sensory information are used to process all sorts of information. And so they can't necessarily be used to process multiple different types of information at the same time. So, responding to a stimulus. It can be either an internal stimulus or an external stimulus. And being able to switch between different stimuli is an aspect of attention. Your ability to shift and to ignore certain stimuli are all aspects of the ability to attend. The prefrontal cortex is the part of the brain that is the primary area responsible for what we understand to be attention. There are some different parts of the prefrontal cortex that do slightly different things to give us the phenomenon of attention. Specifically, the ventral medial prefrontal cortex, so ventral, think kind of the bottom or the belly of it, so orbital frontal, right above your nose, is responsible for regulating emotion and inhibiting some extraneous stimuli, sort of the no button, don't look at that, don't attend to that. It has extensive projection, so the neurons are projecting their dendrites and their axons to the amygdala, the nucleus accumbens, and other areas of the brainstem, which might send signals to the forebrain, encouraging certain actions and behaviors that are somewhat instinctual or automatic. You think of your gut response to something. Okay, you hear a loud bang and you might want to run. So the ventromedial prefrontal cortex would be something that's like, well, no, I'm not going to get up and run right away. I'm going to ignore that stimulus because perhaps the guidance from the dorsal prefrontal cortex, you're getting, oh, no, I can associate that stimulus with that's just a door banging. That's not necessarily a gun firing or something of that sort. So ventromedial prefrontal cortex is the inhibiting extraneous stimuli, either internal stimuli or external stimuli. And then you have the top-down direction of the dorsal prefrontal cortex to guide where exactly you are directing your attention. What stimuli do get all of the energy of the brain to be processed. As a general rule of thumb, it's reasonable to think about moving from the most posterior aspect to the most interior aspect of the brain, as though as the farther forward you go, the more integrated is the functioning of the brain. So in the most posterior aspect of the brain, it's processing very primary visual information, and the farther interior you go, the more complex integrative activity is going on, ending with the frontal lobes, obviously, and the prefrontal cortex, which is highly integrative, taking into account all sorts of different bits of primary sensory information. In addition to the prefrontal cortex, there are a number of other areas that are involved with the phenomenon of attention. The cerebellum is often known to be responsible for coordination, sequencing, and timing of movement. However, it's often not appreciated that it's intimately involved with the coordination, sequencing, and timing of thought as well. People who have ADHD will frequently have difficulty ordering and sequencing their behaviors and even their thoughts. And that is a function that is worked on by the cerebellum as well. And there have been functional MRI studies demonstrating differences in activity in the cerebellum relative to someone who does or does not have ADHD. It's also known that stimulants will activate the cerebellum in some way, and that children with ADHD tend to have smaller cerebellum than children who do not have ADHD. In addition to the cerebellum, the parietal lobes are also noted to participate in the function of attention. We notice this particularly with the phenomenon of neglect. When someone has an injury to the parietal lobe, It's not uncommon for them to demonstrate the symptom of neglect, where they're unable to attend to stimuli in the contralateral visual field. The nucleus accumbens is another of these areas of the brain that's responsible for the phenomenon of attention. The dopamine neurons of the nucleus accumbens send projections to a number of different areas of the brain, the amygdala, the prefrontal cortex, and so on, and have both a tonic rate of firing as well as a phasic firing or a burst firing that occurs when there's a particularly pleasurable stimulus that comes to attention, comes to mind. So the fine-tuning of this tonic firing of these neurons with the burst or the phasic firing of these neurons in response to a stimulus is part of what goes into the phenomenon of attention. When this is dysregulated, when there's not sufficient tonic firing of these neurons, it can be difficult to attend to something because it's harder to engage and things will not be as innately pleasurable. So there has been some evidence to suggest that there's a difference in the tonic firing of these neurons in patients with ADHD, which is ameliorated or improved with stimulant medication. Obviously, too much stimulation with these of these neurons or too much activity can lead to problems as well. So it's a relative balance of the tonic firing versus the phasic firing. That's important to keep in mind. One interesting thing to note about the nucleus accumbens and dopamine is that patients who have ADHD have a higher concentration of a dopamine transporter in the nucleus accumbens. And so a dopamine transporter in the nucleus accumbens would mean it's taking up the dopamine from the synapse and returning it to the neuron, therefore decreasing the availability of that neurotransmitter to stimulate a postsynaptic receptor. And you can imagine if there's less dopamine around, less of that tonic stimulation, difficulties with attention. A lower density of these transporters correlates with better impulse control. Or conversely, a lower density of the dopamine reuptake pump correlates with better impulse control. So basically, the more dopamine you have around, the better impulse control is demonstrated. There is also a normal decline in this transporter density as the brain matures. Psychiatrists often tell people that your brain is not fully matured until your mid-20s, and this is one of the lines of evidence which causes us to make such claims. One final note about the prefrontal cortex. It receives norepinephrine and dopamine projections from the ventral tegmental area as well as the locus ceruleus. So those are lower down. They are not forebrain or midbrain or lower regions. And the level of stimulation of the prefrontal cortex with dopamine and norepinephrine does impact the level of firing of the neurons in the prefrontal cortex during these two different phases that are responsible for working memory. Working memory is often defined as the amount of information you can kind of hold in your head for a brief period of time. So you hear a phone number and then you repeat the phone number and you dial it on the telephone. That's the example that's often given. While receiving the cue, so hearing the phone number, there are certain neurons that are firing. While you're holding the information in mind, those same neurons are firing along with some other neurons. And then obviously when you execute the task, you discharge the information, then the firing of those neurons decreases and you forget the information basically. There's a limited capacity in the prefrontal cortex to hold information. So obviously your working memory, we think it's pretty good if you can remember a 10-digit number or things of that sort. The level of firing of dopaminergic and noradrenergic neurons from the ventral tegmental area and the locus ceruleus respectively, projecting to the prefrontal cortex, accounts for how well, so how few errors you make, and how long you can hold any bit of information in mind. So the stronger the noradrenergic and dopaminergic stimulation of the prefrontal cortex by those other areas of the brain, the better you'll be able to hold information in mind, the better your working memory. Now, working memory is one aspect of attention that is sometimes impaired in people with ADHD. So to quick recap, the prefrontal cortex, the nucleus accumbens, the parietal lobes, and the cerebellum are four main regions of the brain that have all in some way been implicated in the phenomenon of attention and have some evidence to suggest that they are dysfunctional or functioning in different ways in patients with ADHD relative to people who do not have ADHD. So what exactly is ADHD then? It's a neurodevelopmental disorder where the patient will have deficits in attention and inhibiting excessive activity or hyperactivity. Keep in mind that what counts as inappropriate hyperactivity or poor attention is going to be relative to the person's stage of development. So you wouldn't expect the same level of attentiveness in a 5-year-old as you would expect in a 15 or a 50-year-old. Additionally, when you find symptoms of inattentiveness or hyperactivity, you have to find some impairment as a result of these symptoms. If there's no impairment of the symptoms, then there's no diagnosis. There's no problem that's resulted from it. And you'll often note that many people who do have ADHD will find particular niches in their professional lives or in their hobbies which are conducive to the way their brain works, where there is no impairment as a result of their relative inattentiveness. It's also important to note that ADHD is one of many circumstances or problems or disorders which might cause attentional difficulties, and to not prematurely attribute to a neurodevelopmental disorder something that is actually due to a different condition or different stressor or substance. Key things to look for when making a diagnosis of ADHD, or something that would suggest that there is not ADHD present but some other cause of attentional impairment, would be if the impairment or the problem is episodic, so it kind of comes and goes, or if it's new onset. If so, all of a sudden the patient has problem concentrating when they didn't before, it's probably not ADHD. So if it is chronic and pervasive, occurring in multiple areas of the person's life and functioning, and has been there since childhood, okay, maybe ADHD. If it's episodic or new onset, probably not. There are a number of classic things that you'll see in a patient reporting symptoms of ADHD. You'll often hear stories of poor hindsight or poor foresight and no hindsight. So people will do things without thinking, and then they won't reflect upon them after they've done them. You'll often find people are very impulsive, and so that may end up with frequent car accidents, or other impulsive purchases, things of that sort. People aren't able to sequence events, kind of plan ahead and organize their behaviors in a way that would lead to better results. So poor time management and poor planning are hallmarks of this. Oftentimes we'll ask people about their bedrooms. Are they organized or not? A kid, you ask about what does their backpack look like, things of that sort. So organization, planning, kind of this sense of timing, harkening back to the cerebellum there, thinking how am I organizing my life, organizing my thoughts and my behaviors. So where does ADHD come from? Well, there's substantial evidence that there's a genetic component to ADHD. There's a significant heritability. So it's a good thing to ask your patients, hey, look, do you have ADHD in your family? Is your mom or dad or brother, sisters, things of that sort? Because if there's a positive family history, that can help support a diagnosis of ADHD. There is evidence of neurochemical imbalances for ADHD. That's largely through studies of noticing, hey, how do our medications work? So we know that, hey, look, if we give people stimulant medications or medications that increase relative levels of dopamine and norepinephrine in the prefrontal cortex, hey, that improves the symptoms of attention. That's the same logic that's used in the neurotransmitter hypothesis of depression and anxiety. It's relatively indirect evidence, though, so I wouldn't lean too heavily on that. So sort of a presumptive hypothesis that there's some dysregulation in norepinephrine and dopamine because we know that by adding more, things get better. Not necessarily bad logic, but hardly conclusive. There's also some neurophysiological data that suggests that there's differences in EEG activity in patients with ADHD and those without. There are some neuroanatomical differences in patients with ADHD and those without. I've mentioned the different sizes of the cerebellum. There's also some plenty of fMRI and PET and SPECT studies which suggest that there's different sizes or volumes of gray matter in different areas of the prefrontal cortex, the anterior cingulate cortex, and other parts of the brain as well. Of note, stimulant use, like illicit drug use, has been known after the fact to cause a thinning of the gray matter in a number of areas of the brain. It's not entirely known how prescription stimulant medications impact the thickness of the gray matter of the brain. There's some evidence to suggest that, hey, look, somebody with ADHD is going to have a thinner gray matter in different areas of the brain. And we don't entirely know if, hey, is that because this person's been on stimulant medication for a decade, or is that because of ADHD? Some of that remains unclear. Additionally, there are developmental exposures that can cause problems with attention and brain development. So if mom had some prenatal exposure to a toxin of some kind or an infection, that can substantially impact the development of the child's brain, possibly resulting in ADHD. As well, there are a number of psychosocial circumstances which may cause or contribute to the presence of an attentional difficulty that may look like ADHD or may actually cause ADHD. So a child who is abused or neglected in some way may have significant impairment in attention. Whether or not that's the same thing as ADHD is something to consider debating. The statistics for the prevalence of ADHD are noteworthy. Roughly 5% of school children have a diagnosis of ADHD. And 60 to 80% of those children continue to have symptoms in adolescence and persisting to adulthood, resulting to about a 2 to 2.5% of adults who might carry a diagnosis of ADHD. As mentioned previously, there's a genetic component to this, and so it's not surprising that the rate of ADHD is between 2 and 8 times higher in patients with a family member with ADHD. It's important to keep in mind that comorbidity is very common with ADHD. Like I was discussing previously with the different levels of the brain, if you have a perception problem or a first order processing problem like an attentional difficulty, that may eventually result in a fourth order problem like depression or anxiety. So it's very common for people with ADHD to perform poorly in school. They have develop anxiety about their poor performance, and that can eventually lead to an anxiety disorder. And so you end up with roughly 70% of people who are adults meeting criteria for ADHD who also have a second disorder. When there is such comorbidity in place, it can be difficult to decide, hey, is this person having problems concentrating because of anxiety, or are they having anxiety because they have problems concentrating? Teasing that out can be difficult sometimes, but it's not impossible.